mentioned that there's work to do on doctor-patient communication. I would love to hear your thoughts on how we as advocates can help with that.
It's the ability to listen that I think is the key feature. Some people can listen, some people have preconceived notions, and they go into a conversation trying to get the information they need to support their preconceived notions, rather than going in with what I call the blank slate, the Zen Buddhist, blank mind, and just really listening and letting that information kind of process. I don't know how much of that can be taught. I don't know how much of that is innate or if something you learn by age 3. This is really what I don't know, because what I found is the people who listen best not only make the best decisions, medically, but they connect better. And because they let go of the pretense I am the expert in this communication, and you are here to serve my wisdom, is that they connect better on a human level. And we're all, or pretty much all of us, are very skilled at connecting human to human. That's how we get through life for the most part. That part shouldn't go away when you become a physician. And I often will start the conversation with patients by saying, there's 2 experts in the room. I know science and medicine, maybe more than you. You know more about you than I ever will. And so together we have to come up with the right answer that's right for you. I can't do that by just talking about science and medicine. You have to meet me with 50% of the information about you to try to get us on the level playing field as 2 humans. Certainly the fellows I've worked with have within the context of their own personalities sort of dealt with that. But I think it's a really important problem, and I think it's a really, really critical issue. Because very often the kinds of concerns that people with the disease have are not the kinds of concerns they had 20 minutes earlier when they didn't know the disease, and they're not the concerns of the physicians who are dealing with them who don't have the disease. Although at my age I know a lot of physicians who do have diseases, and almost universally it makes them better doctors, by the way. All right, which gets. I remember when I was a young whippersnapper doctor, I said, what do we need these advocates? I'm the patient advocate. I'm out there to lead them to the whole. And I think you need the experience of life to tell you that unless you've been there, you may not really understand the nuance. We're willing to work with you, and we really need more educated, involved advocates really at the table, as we were saying before. It makes a dramatic difference. Discussions in the room about clinical protocols are totally different if you're talking about a new metastatic disease protocol and there's somebody with metastatic disease in the room that people can relate to person to person. It's an entirely different discussion. All right, yeah. And that just being there, they don't have to say a word just because they're listening. All right. And if they say something, that makes it even better. And I think we have to build up, a community. As I've said before, in many cases, every human on Earth is either an actual healer or a potential healer, and every human is simultaneously either an actual patient or a potential patient. And if you think about that, we're all the same.
You wrote a piece that is still on our website you wrote it, How to Get the Treatment You Need. And you said the very things you said now, but you added one other part that struck me, and that is, and you said it more eloquently than I will say it now, but you said if you don't feel that you are having that connection with your doctor, then consider looking elsewhere. Yeah. And I think that gave a lot of our patients permission to say, because we often think doctors are all-knowing, to maybe consider looking at another place, even though you're in a very difficult disease.
What I actually said, it got me in a lot of trouble, is if you don't like your doctor, the odds are your doctor doesn't like you. I
didn't want to say that. I remembered it.
That's what I actually said. But you got to liven up the audience. Yes. In there. It didn't mean it exactly in that kind of sense. But the thing is, every one of us has an instinct. Yes, very soon when we meet somebody, am I connecting to this person, right? And that's what humans are really very good at. We know very, very quickly, is this somebody that I can really connect with? And and it's kind of like a bad marriage. You can like them both, but it's a bad marriage. They're just not connecting. You can be friends with both of them. They're lovely people. This is just not working.
But that's because it's a conversation.
Yeah.
Okay. 20 years ago, it wasn't. Doctors told patients, "Here's your treatment protocol. You're diagnosed with breast cancer. You have AC or CMF chemotherapy. Go ahead. This is the side effects." It has changed. Right. It is now a conversation. So to your point, doctors need patients to come part way, and it is a dialogue, it's a conversation, and some people you just can't have a conversation with.
Yeah, can I, well, and if you can't, then change doctors. I mean, do it soon before you get too deep into it, because I think that really is a very, very important part of what you have to do. The other thing I want to say to the doctors who are going to listen to this as well is that and I hear this especially from younger people. Larry, look, I don't have time. I mean, if I have to see 4 patients an hour, I'm doomed, all right? Because either I'm an academic, I got to get back to the lab, or I'm in practice, and if we don't have a certain throughput, there's no way I can pay for my nurse and these other things. This is something else that I've learned, all right? And I'm saying this to the physicians out there in this kind of situation. Spending a little time in the beginning to really develop that rapport with the patient saves you an enormous amount of time, long range. Because you don't have to constantly defend yourself. You can say things very, once you've established that good relationship, you can communicate much more efficiently. And I think it may be a little front-loaded. You may have to spend more time in the beginning, learning about each other and learning about things that you're interested in. And I always try to do this with my patients, is find out some area of mutual interest that has nothing to do with health, so we can have that to talk about and establish a more human relationship. And it saves you a lot of time later on, all right? Especially at like critical moments where you have to make decisions sort of quickly, and you really have established that trust, where you lay out the facts, you lay out the reasons, but there isn't that uncertainty, about you that sometimes drags conversations out. So I'm just saying this to the physicians out there who are going to be seeing this, is that it really is worth the time to establish that human bond.
What you said, Dr. Norton, is so important. I wrote a book called Seeds for My Patient. The things that patient of the year of the last 30 years have planned in my life and what I learned from them. And I think, I after many years of practice medicine, I realized it's not them and me, it's not the patient, the doctor, it's us. And like you said, we all potentially patients. Some have already diagnosed, has been diagnosed, and some haven't. And I tell the patient, we have to be on the same team. I'm not the expert. We are both kind of meeting. They expect to get a great treatment, but it goes beyond that. And so that connection that you talk about they feel like if you're trying to connect that, probably the prognosis is even better, because otherwise you wouldn't be wasting all this time. I'm talking about exercise and body mass index and the cancer. I'm trying to say it's not going to be just this breast, it's your whole body we want to take care of it. And so intrinsically gives them hope, because we wouldn't be worried about the body mass index if we think they're going to just drop dead in a month or something will happen. So that connection, and when they realize that you wanted to know who they are, I say you need to believe your diagnosis, because you're going to be getting treatment for it. We know that patient with metastatic disease could be alive for years. Every person is a little bit different, and we need to find out who's going to do what. But that connection, that mutual work that we need to nurture, and you're right, it takes times. And right. Patients are willing to wait for you because they know that you're going to take time to get them through this, and it's something that could happen to you and me. We could be diagnosed tomorrow with cancer. So it's that major connection.
It's extremely important for the patient side to say, what do I have to do to get better? And not come in otherwise. So I saw a patient, a couple of weeks ago that came up from Florida. She had a breast cancer, primary breast cancer years before, and now she had nodules in her lung. Who came to see me for a second opinion because the physician there said we should get a biopsy and find out what we're dealing with, and she was very resistant to getting a biopsy, and she wanted to know whether it was absolutely necessary or there's something else that can be done. Okay, to make a long story short, biopsy shows tuberculosis. It's not metastatic breast cancer. Wow. And it's being treated for tuberculosis. It's an unusual type of tuberculosis. It's an unusual pattern of tuberculosis, but that's really what it shows, and she's getting treated for an entirely different thing. And she could have easily been treated for metastatic breast cancer, which and have died of tuberculosis, as a consequence thereof in that situation. So that the important thing for her to have taken into the message is, listen, if this is really what I have to do. Now, she did the right thing. She got a second opinion. Yes, a biopsy is necessary. She went ahead and did it. So that's not unreasonable at all. But that it's very important, not that your first communication with the doctor is not, whatever you do, don't hurt me. That shouldn't be your first communication. Your communication, whatever you do, cure me or help me. That should be the first communication. And then if you don't like what you hear, you can make up your own mind. But you shouldn't screen out your options by shutting the door on options before you actually hear what the options are.
And thank you to all of you for making time to spend with us.
Thank you.
Thank you for inviting me.